Do y'all have anything for me before we get started? Grades will be posted by 3 o'clock today. Do y'all have anything for me? You're welcome. Okay, let's get started where we left off with shock, okay? Like an average, the passing average? I didn't print out the like the demographics on the whole thing, but y'all did well. Yeah, and Thomas, they have something in ExamSoft that will tell y'all that, but I have to check to see if I can release it to you. If you do exam review with me, I can tell you individually, but I don't know that I can release the stuff. Okay. All right, let's get started. All right, what's shock? Y'all not going to help me today? Yeah, that's a type of shock, hypovolemia. So shock is the failure of the circulatory system to maintain adequate perfusion to those vital organs. So which patients are at risk for shock? What are some things that can cause shock? Sepsis, yes. Infection. Hemorrhage. What about trauma? Burn can. Okay, so list what are the types of shock? There's 5 of them. So we have hypovolemia, cardiogenic, neurogenic, septic, and anaphylactic shock. And I'm going to put this next screen up because it has a little bit of a kind of a cheat sheet for y'all. So hypovolemic shock is the reduction in blood volume. So it's when you lose blood. So think of hemorrhage. Burns aren't necessarily a blood loss, but they're a fluid loss. So they fall under hypovolemic. Anything that causes that severe fluid loss or dehydration. Ascites can cause hypovolemic shock because that fluid comes out of the circulatory system and goes into the interstitial tissue. Third spacing, that's right, third spacing. So hypovolemic shock is treated just by giving them volume back. So you've got to replace that blood volume that they lost. So you either do that with blood transfusions or some type of volume expanders. And you always want to give them more oxygen. And just think about, why would you give them more oxygen? What happens when you lose blood? You're not just losing blood. What are you losing? Yeah, you're losing that oxygen carrying capacity, right? So when you lose blood, you're losing that hematocrit and hemoglobin also. They're going to help you circulate that oxygen. So you need to saturate the circulating blood with oxygen as much as you can get in there. Okay. And then cardiogenic shock. So the heart is unable to effectively circulate the volume that the body and the tissue needs. So the heart just can't keep up with the body's demand. This can be caused with injuries like MIs, heart failure, dysrhythmias, which we talked about last week. Dysrhythmias, it's ineffective beating, right? So those can cause the body to not be able to keep up with the demand of the tissue because you're not actually getting the blood circulation around. These you're going to treat with oxygen also. And then any medication that's going to increase that cardiac output. Neurogenic shock. It's basically a widespread vasodilation. even though the cardiac function and your blood volume are normal. It happens with spinal cord injuries, drug overdoses. It can happen sometimes with spinal anesthesias. Treatment for this, you're going to administer vasoconstrictors. If the patient has any type of bradycardia with it, you're going to have to give them atropine. You really have to watch these patients for fluid overload because this is not a volume loss. And neither is cardiogenic shock. So cardiogenic shock is not a volume loss either. It's the heart's inability to pump the right amount to perfuse the tissues. So if you start having to give them a lot of meds to keep their perfusion up, you run the risk of fluid overload on them. So you really have to watch how much fluid they're given. Then we have septic shock. We learned about septic shock with systemic inflammatory response and MODS. So it's basically a vasodilation. It's a systemic vasodilation due to the immune response. It happens with an overwhelming infection. The way you treat is you have to find out the original cause, because if you don't treat the original cause, it's just going to continue to get worse. You can't treat the signs and symptoms without treating the original cause. So that can be IVs, antibiotics, volume expanders, and always oxygen. And then anaphylaxis. We all know what anaphylaxis is. So it's that antigen-antibody reaction and a release of histamine. It causes vasodilation and also hypovolemia. There's tons of causes of anaphylaxis. Insect bites, food allergies, allergies from dyes, side effects of medications, blood transfusions. So one of the main things you want to do with them is you have to make sure you maintain an airway due to the laryngeal edema. And their medication is epinephrine. Now, we talked about the medications as we went through, but I'm just going to go over dopamine and dobutamine. They're used for types of shock. So what do they do in shock? Sometimes I have to figure out how I'm going to ask the question to get the response that I want. Yeah, they do those things. But they're also going to perfuse the kidneys. So they're going to increase the contractility of the heart muscle, which is going to increase your blood pressure. It's going to increase cardiac output, and it's going to perfuse your kidneys. And when you're replacing fluids in any of the type of shocks, it's going to be, the rule of thumb is for every 1 ml of blood lost, you give the patient 3 mLs of isotonic crystalloid fluid, like normal saline or lactated Ringer's. And then epinephrine is that vasoconstrictor we talked about for anaphylaxis. That's kind of a quick overview before we go into this case study. So the case study is Micah Price. So he's a 31-year-old male who was rock climbing 14 miles away from the nearest hospital when he suddenly lost his footing and slid 18 feet to the ground. Both of his friends witnessed the fall and said that he slid against the sharp rock all the way down, landing almost standing up position, finally slumping to the ground. He has multiple scrapes over his anterior torso and a large gash over his right anterior upper thigh near the groin, which has been bleeding profusely. A makeshift tourniquet slowed the bleeding. His friends were able to radio the park ranger station for help, and the ranger contacted the medevac unit at the city hospital. The helicopter loaded and evacuated the man. Large bore IV was placed in each arm in flight, and normal saline was administered intravenously. The patient became increasingly disoriented during flight. They reached the hospital about 40 minutes after the fall. On arrival to the hospital, the patient was lethargic but responsive to shouting and sternal pinch. He had multiple abrasions all over his chin, neck, anterior thoracic, and abdomen. A 6-inch long, half-inch deep laceration was noted in his right inguinal region, extending to the right upper thigh. The tourniquet placed in the area was blood-soaked. So on assessment, his vital signs, pulse 122 as he was laying down. Sitting up was 128. Blood pressure 108/60. And then sitting up is 92/52. Respiratory rate is 32. SAT's 88. And temperature is 99.4. Skin is cold and clammy. And nail beds, palms, mucous membranes are pale. And all pulses are weak and thready. As soon as he's cross-matched, whole blood will become available, and their 2 units will be transfused rapidly to this patient. He's got some problems. So here is labs. I just want you to kind of glance back and forth with him as we go through the rest of the questions on this one. So what's his primary problem? He's got a lot of problems. What's the main one? What kind of shock's that? Yeah, hypovolemic. So he's lost a significant amount of blood. And by the description of where they're saying the gash is on his right leg, it sounds like it's pretty much over his right femoral artery. So, it's a lot of blood loss. So some of his manifestations of shock, yeah, it's a problem. He has lethargy. All his vital signs are pointing towards shock. He's lost a lot of blood. So when we talk about early signs of shock, what are some early signs? They're basically compensative signs of shock. What are some of those? Yeah, that's good. Okay, so blood pressure. Blood pressure can be low or normal. And it can be normal for a little bit because the body is able to vasoconstrict and compensate. But the body cannot maintain that. So then you'll see the low. But early signs are low to normal. Okay, so it's either the body's compensating by vasoconstricting or shunning the blood, or it's just not able to keep up anymore. Then your pulse is going to be increased or normal. Your respirations are increased. The temperature can be normal or low during this stage. A patient can be oriented, but they can also be restless and apprehensive with anxiety increasing. Their urine output can be slightly decreased, but it can also be within normal range. Their skin is pale and cool. Their nail beds will be pale, and that's from lack of circulation, perfusion issues. And as their blood pressure starts to decrease, if they're alert, they're going to start getting nausea and vomiting during this stage. As it progresses and you're in this intermediate stage, how do you think it goes from there? Think about this is the part where the body can no longer maintain this adequate oxygenated blood supply that's going to your tissues and your organs. So what do you think starts to happen? So all those symptoms are going to lead or caused by this decrease in perfusion. Right? So think about all the things that start happening when you have decreased perfusion, decreased tissue perfusion. So they're going to have that decrease. Blood pressure is going to drop. The pulse rate is going to increase, but not only will it increase, it will be weak and thready peripherally. Respirations are still increased, but now they have some dyspnea. How's your skin? If your skin, that's right, Rebecca, it's cold. Sorry, I didn't read that yet. It's hard for me reading my notes, reading y'all's chat. Their skin is cold and moist. What starts happening with your urine? Decrease, that's right. And then after that, they go into this refractory stage, and it really is irreversible. And this is when the organ damage starts. So you're basically having cellular ischemia all over the body. And that leads to the organ failure. And then organ failure leads to what? Death. That's right. So it's just progressive decreasing level of consciousness and unresponsive. Blood pressure will become unmeasurable. Then they're unable to do the vital organs. You'll hear it called critical shunning, and that'll start happening. We're in that signs in the intermediate stage. Your body knows it's got to save your heart and head. So as it starts getting worse and worse, your body will start critically shunning your blood to be able to perfuse your heart and your brain, which your kidneys, your bowel, I mean, all your extremities, they're out of luck at that point when your body starts doing that, because they basically vasoconstricted every little vessel and capillary go into those areas to be able to keep the blood volume adequate and the output adequate for these two areas, the heart and the head. They will stop producing urine at this point. Their respirations will be all over the place. They'll be irregular, very labored, just slow and irregular. And what happens when hypoxia starts developing? What's your blood gas look like? Kind of acidic. All right, acidic, but what? Metabolic. That's right. So as hypoxia starts and is not treated, they go into metabolic acidosis. And once they go into metabolic acidosis, it's really unlikely that they're going to recover. You're not going to be able to reverse them at that point. It's gone on too long. Okay. So he had an EKG and it showed a slight depression. I don't have a pop-up box over that. A slight depression, and his urine out first 60 minutes in the ER was 20 mLs for that hour. It was dark yellow, had elevated creatinine and BUN, and his nail beds are pale and he's lethargic. So what are the causes for each of these findings? His urine output, we just talked about, his output is low because of perfusion to the kidneys. Orthostatic hypotension. Why? It's twofold. It's twofold in this. He did have a large amount of blood loss. Orthostatic hypotension. When you stand up, if you're sitting down or laying down and you stand up, in a split second, your body constricts all your arteries to be able to keep your blood from just running completely to your feet. So as your body loses the ability to do that, you stand up and all your blood rushes down to the bottom before your body takes 2 seconds at this point to constrict and get your blood volume back up. That's what happens with orthostatic hypotension. So he starts having that. It's because his body it's a low blood volume. It makes it hard to maintain this adequate, but also the between the brain and the body, there's a disconnect because of the confusion and the mental state from low perfusion of the brain, but also your body's in a stressed out state. So the response time is low, and they're already vasoconstricted, but their body's not doing that extra vasoconstriction. Does that make sense? It's not even a second response that our body has when we stand up, but anytime that response is still, or there's something going on in your body, and that response is 1 second or 2 seconds from happening, your blood volume rushes to gravity, right, which is down towards the bottom, before your body then vasoconstricts and it starts pumping it back up. And then the elevated creatinine and BUN, we know that's because the kidneys, they're not able to get rid of, excrete the normal waste production. So the kidneys are taking a hit. And also the decreased perfusion to the kidneys makes it difficult for them to get the waste out at that point. The nail beds and mucous membranes. So this is this arterial vasoconstriction when I was talking about, and this is the very beginnings of critical shunning, when it starts saying, okay, these little capsules down at the very bottom, we're gonna clamp them off and not let blood go down there because I need some more blood up here towards the central core. So that's going to start, and that's going to really limit that blood flow. It's going to cause this mucous membranes, and especially the nail beds, the tips of your fingers, all those places where you check for perfusion peripherally, they're not going to be perfused anymore. So when you push and you're looking for that refill, there's not going to be a refill. It's just going to be white and blanched. And it'll already be white and blanched before you pinch it. So the disorientation and lethargy, is all coming from the reduced blood flow to the brain. So this does definitely alter the central nervous system and its function. And when it goes into extreme cases, this patient goes into a coma. And ST segment depression, what does that tell you? What did we learn last week? Y'all didn't learn last week because y'all were worried about test 2. Think about it, the ST segment depression. What about MI? Because what is an MI? An MI is ischemia, right? So it's the lack of perfusion to an area of the heart. So the reduction in the systemic blood flow reduces the flow through the coronary arteries. So the heart muscle is deprived of oxygen supply. It becomes an MI. If it's not, if it's not reestablished pretty quickly, it's irreversible damage. Just the same as an MI. I mean, it's the exact same. If you don't reperfuse that area, it's going to die. Okay, so he gets this whole 2 units of blood, of whole blood. His hematocrit is close to normal range. So why was he given 2 units of whole blood? So on the flight over, he was given normal saline, right? Because blood wasn't available at that point. And when you're giving normal saline or lactated ringers, you're just giving volume. You're not giving back all the stuff that is in the blood. So you need that hematocrit. You need the hemoglobin. He needs platelets. He needs the whole volume of that blood. Okay, even though his hematocrit is normal or close to normal, you would still give whole blood because you have to give that back. When you start giving this crystalloid fluids, you're diluting out what's there, but you're adding volume to give the body something to circulate and to perfuse with. What's important when you're giving this crystalloid fluids? What's important to check? Vital signs, yes. Let me see what question to ask to get you to answer this. Okay, yeah, so all the vital signs, right? But what's one thing you're really going to be looking for? Think about the fluids. Temperature, yes. So you're going to check the temperature. Why are you going to check the temperature? What's happening? Is room temperature the same temperature as our body? No, it's not, right? So you're talking about replacing a large amount of volume in this patient with room temperature fluids. You start pushing large amounts of room temperature fluids, what are you doing to the body? You're cooling the body off, right? As you cool the body off, what happens? The body starts to slow down. Temp will drop, heart rate will drop, respiratory will drop, everything will start, circulation starts dropping because you're cold. Your body starts clamping up. So when you're giving these crystalloid fluids or the isotonic crystalloid fluids, when it's possible, you give them warmed. Warmed is not in a helicopter. Warmed is in the hospital. They'll put them in a warmer and you can give them warmed. You just got to make sure the patient's warm blankets. I've seen those bear huggers that keep people warm also. You just really have to watch their temperature while you're giving them stuff like just room temperature fluids. So you have to really watch for hypothermia. Yeah, they can go into shock. So you start cooling somebody off and you have a whole nother set of problems on top of your actual hypovolemia. So not only when you are given this isotonic or crystalloid fluids, you're diluting more of the oxygen carrying capacity. So he leaves, he's lost all this blood, he's in the helicopter. You got to get volume in him so you can keep the cardiac output up. But as you're giving him volume, you're not able to give him blood. So you're basically giving him just fluid, just dead fluid. And what's that doing in the long run? It's diluting out the blood that was left. So if this patient were stabilized, how would we how would his hematocrit change over the next 24 hours? In 24 hours, what do you think your body starts replacing faster? It's easier for your body to replace plasma. So it'll start replacing plasma faster than it's going to replace those red blood cells. It takes a little bit of time for that bone marrow to get stimulated and you start putting out red blood cells, but your body can start pumping out some plasma pretty fast. And plasma is better than fluid, just this bag fluid. Okay, so over the next 24 hours, you're going to expect that the hematocrit to slowly continue to decline because the body's got to catch up with it. So it won't mean that usually when you see a decrease in hematocrit, you think someone's still bleeding. And after everything's been checked on him, and yes, he could have internal bleeding. At this point, he does not have internal bleeding. So after you've verified that, that drop in hematocrit is just the fact that his bone marrow has not caught up with what he needs to be produced yet. And that would be a normal finding right now. So don't mistake that for continued blood loss. Does that make sense? I'm not saying that that's not something you're going to check out on this guy when he comes in. He's obviously banged up. He fell, slid down a rock and he's all bloody. But you're going to do $1 million workup on him and you're going to have everything scanned. So once he's stable and nothing's bleeding, know that that hematocrit drop is just production need to catch up with body's demand. Okay, so your interventions. So think about your interventions first. You got to identify and correct the cause of the shock. So, how are you going to do that? You have to have a rapid response, right? Faster the response, the more stable, the stabler, if that's a word, stabler, I guess that's a word. You can stabilize this patient faster. And the faster you stabilize them, the less damage that is done to the body. The easier it's going to be to bring them back to functioning capacity, and they're going to be easier to manage. Okay, and then you're also going to be monitoring them for developing any signs and symptoms of any type of shock or hypovolemia at this point. So things you do for hypovolemia, you've got to maintain their blood pressure, and you can do that by them being supine in bed. You may have to elevate their legs so the blood is able to shift properly. You're always maintaining the airway. These patients have got to have oxygen. You got to keep them warm. Don't let them get cooled off by the fluids they're being given. So maintain adequate respiratory function. How are you going to do that? Talked about giving oxygen. What else can you do? If you're giving oxygen, you have to monitor, right? So you got to have O2 stats that are within normal limits. How do you know if a patient is ventilating properly or breathing properly on their own? What tells you that? ABG. So you got to get some ABGs on the patient. Breath sounds. Breath sounds can tell you a lot about a patient. You don't always have to just have tests and numbers. And then also you've got to, even with the oxygen point and the respiratory function, you've got to be able to assess for their level of consciousness and make sure there's no confusion. You have to maintain adequate circulation and tissue perfusion. How are you going to do that on this patient? You got to stop the bleeding in him. Yeah, so you got to give him some blood. You got to maintain his fluid volume, so he needs volume. So whether it's blood or blood products or IV fluids, depending on what part you're at in his treatment. And you need to monitor the input and outtake. And then as far as venous excess, if you saw or heard in the helicopter where they put 2 large bore IVs in him, why do you think they did 2? Okay, a lot of good answers over there. Okay, 2, let me tell you why. You put 2 large bores in because you're not putting this patient necessarily on a drip factor over there. You're opening those bags up because you have to get fluid in this patient, especially hypovolemic shock. It's fluid replacement. Those bags are open up and flying in. When you have these bags opened up, you're putting a lot of pressure on that vein that's having this flow in. So you risk definitely blowing that IV, and you always want to have at least one open. So they're going to be hard to start an IV in the first place because of their perfusion, but you need to have two going at all times. So if you blow one, you still have one open while you're getting another one going. You've got to have it for meds. You got to have it for due to the high rate of infusion that you're going in, and how fast and how the volume of fluids that you have to get in this patient. And remember, which two do you really have overload? Which types of shock? Because they're not because of a volume loss. Cardiogenic and which else? Yep, neurogenic. That's right. So you got to really monitor them closely for fluid volume overload. Okay, you got to maintain this cardiac output and vascular tone. How are you going to do that? How are you going to monitor blood pressures? Yes. Why is the art line better than a cuff? More accurate. That's right. Your art line is pretty much the pressure that's going on at that very moment. The cuff has a lot of variables to it. Y'all know this from just first semester and probably being in some clinicals now. You can put a too big of a blood pressure cuff on me and my pressure is going to be low. You put too small, my pressure is going to be high. A normal size cuff on a patient that's in hypovolemic shock, you're probably not going to get a reading at all, honestly. So you've got to be able to have art line access to be able to really monitor the blood pressure on this patient. And then administering fluids to increase the circulating volume, right? Because you got to have fluids to keep this cardiac output going. You're going to always be monitoring for the end organ perfusion to make sure that they do have perfusion. So the kidneys, so urine output, is the patient oriented? Do they have peripheral pulses? How's their peripheral refill, cap refill? And something important is to monitor the renal response. You put in a catheter. It's not just to be able to get the exact amount measurement of urine all the time, but it can tell you very quickly whether or not your kidneys are perfused. It can often sometimes be one of the first signs of decreased cardiac perfusion, not just in shock, but in anything. Okay, so you want to maintain greater than, what's your normal urine output per hour? Yeah, you want greater than 30, right? So you want to make sure that you're maintaining urine output greater than 30. And if you need pressors to do that, they'll have to be given at this time. You're also going to be monitoring for that BUN and creatinine. And then maintaining homeostasis. So you have this ongoing neurological evaluation that's going on. You're checking their orientation status and making sure they don't have loss of consciousness frequently. And you'll reorient them if needed. You also want to minimize the sensory overload that's caused by the hospital environment. So the alarms, people coming in and out, all the sounds. These patients are very sick. They're usually close to the nurse's desk, which also means they're close to a lot of noise. You want to evaluate their GI status. So these patients have taken a hit everywhere in their body, and we talked about critical shunting. So the stomach and the gut have not been perfused properly. So these patients need to be NPO, need to have frequent oral hygiene, need to monitor for the return of bowel sounds and watch for any distension. And you could possibly put down a nasogastric tube, basically to monitor for any type of ischemia, any type of residuals that are in the stomach. And provide emotional support. So providing emotional support to the patient if they're awake, family always, procedures and tests. You always want to keep them informed of the condition. So that's shock. What questions do you have? No questions. Yes, we can. Let me get back to them for you. Okay, so we talked about dopamine and dobutamine. They're going to increase the contractility of the heart. You're going to have your fluid replacements, which are going to be considered. Yes, you can reverse neurogenic shock if it's caught. It's the same stages as other shock. If it's caught soon enough, all shocks can be reversed. You have fluid replacement. Remember, it's 1 ml for every 1 ml of blood loss. The patient gets 3 mLs of isotonic crystalloid fluid. Epinephrine and neurogenic shock, atropine for bradycardia. Septic shock, you're going to have your cardiotonics. Remember, always oxygen. Hypovolemia is your volume, your fluid volume, whether that's blood, whether that's isotonic crystalloid fluids, volume expanders. Okay? You have to think about what's caused the shock and what the body needs. Anything else on shock? Okay. Let's go to aneurysm. So, what is an aneurysm? Okay. So, it's a dilation or a sac that forms within the wall of an arterial vessel. It can involve one layer of that vessel or it can involve all the layers of the arterial wall. It is due to a weakening. It does cause a bulge, and it is blood that's pooling. And there's 3 types of aneurysms. So you have abdominal aortic aneurysm, thoracic aortic aneurysm, and dissecting aneurysm. Yeah, so the AAA, it occurs just where it says it does, in the abdomen, and it's below the renal arteries. And thoracic aneurysm is located in the thoracic area of the chest. And dissecting is just between the layers of the vessel wall. So they can all be dissecting. So what are some clinical manifestations of abdominal aortic? They can be asymptomatic. They can have abdominal pain. What other kind of pain can they have? Epigastric, back and flank pain. You may be able to palpate a pulsating mass in their abdomen. What are some signs that it's ruptured? Think about what happens when it ruptures. Yeah, rapid hypotension is what's happening. They're losing blood volume. So rapid hypotension, they can go into shock very quickly. There'll be tenderness and distension in the area and hematoma formation. What about thoracic? It can also be asymptomatic. It can cause dysphagia. and it's due to the pressure on the laryngeal nerve in the esophagus. It can also cause hoarseness due to the pressure on the laryngeal nerve. The pressure on the vena cava can cause edema of the head and arms. And what are signs that this one's ruptured or dissected? Hypotension and shock, yes, because it's blood volume again. But what are some other signs of it? Where's the pain located? So it's going to be a sudden, constant, um, excruciating pain in the chest or the back area. Then dissection is where you get the sensation of tearing or ripping. They'll have that sudden severe chest pain also. And then it can radiate to the neck and the lower back. So we're going to start with Miss Martha Majors. So she's a 45-year-old female who comes to cardiology clinic for lightheadedness, fatigue, and feeling of a skipping heartbeat over the past few weeks. She says she has not had what she would call chest pain, but she has had a lot of upper back soreness lately. She might have pulled a muscle. Her vital signs are blood pressure is 149/91, pulse is 89, respiratory rate's 15, SAT's 96, and she only takes a multivitamin. Here are her labs. Y'all can look over them as we go through. So, what signs and symptoms are immediate concern that she's reporting? What what about the heart sound? Yeah, heart skipping a beat. So what does that tell you? The potential of what? It's the potential of an arrhythmia, right? And really, that arrhythmia could be causing all those other problems. It can cause the fatigue, it can cause the pain, cause the lightheadedness. Okay, so what would you your first step in evaluating her complaints? What would you need to see first? Yep, an EEG. And what's it going to show you? It'll show you heart rhythm, so it'll show you if there's any rhythm disturbances. It really shows you 12 views of the anterior side of the heart, because each one of those leads shows you something. And her feeling these skipped beats, the ECG, EKG, is just a great way to evaluate the concern because it's really going to show you what's happening when those beats are skipped. Okay, so what our EKG shows you is that she's had 3 PVCs per minute. So should we be worried about these PVCs? Look at how many she's had. She's had 3, right? 3 per minute. So you wouldn't be worried about this yet. So she's having, it's less than 10 PVCs per minute. Okay, so three or less are not associated with any type of risk of cardiac risk. Yes, Jessica.
Okay, sorry. Last class, I was a little out of it. And you said something about PVCs, and I thought you said more than 3 in a row was like abnormal, but is it more than 10?
No, but look, this doesn't say 3 in a row. It says
Okay.
3 PVCs in a minute,
Okay.
right?
Uh-huh.
Yeah. More than 6 are back to back, right? So this is 3 PVCs per minute. So it could be, I mean, her heart rate was 90 or 89 or something. So that's not very many for that. Okay, so we're not quite concerned that she's having any risk of cardiac problems at this moment. So what can provoke PVCs? What can cause PVCs? irritation. Think about stimulants too: stress, tobacco, caffeine, exercise. Okay, so even though our initial evaluation has been very benign, Martha still has the same symptoms. The physician orders an exercise stress test. So what does the stress test tell you? What does it do? It's going to determine if there's an adequate blood flow to the heart, right? Whenever you're increasing your activity, it's going to see if there's an adequate blood flow. So what does it involve? These patients are on a cardiac monitor, they're on a blood pressure machine, and they're monitored as they gradually increase levels for cardiac demand. And they do that by increasing the rate on the belt, or the pace on the belt of the treadmill, and increasing the angle of elevation. And a chemical stress test is basically the same thing, except for it's done with medication, and it's done for patients that aren't able to get on a treadmill. Okay, so she's getting this exercise stress test instead of the chemical stress test because she is able to exercise and she is stable and she doesn't have any mobility limitations. So the results of her stress test is an increase in PVCs with minor changes during her stress test. She blacked out during the test before maximum exercise was reached, and due to her passing out episode, she was admitted to the hospital for a repeat of all her cardiac labs and a further workup. During her episode, a resting cardiac echo was ordered because of her episode, sorry. So what's the echo going to tell you? It tells you about the heart. It tells you about how much pressure is coming out, blood flow. Yeah. So her ejection fraction is 53%, and there were no clots seen in any of the chambers. So they're still concerned about it, and the physician says she's been having and asked the patient or asked the physician if there is any more diagnostic tests that can be done before she is discharged, and he recommends a cardiac cath. So the cardiac cath shows no major blockages seen in the arteries. The most occluded vessel is 30%, so no stents were needed. So when are stents usually done? How much occlusion will cause a stent to be done? 60 or greater. I think your book says 70 or greater, so go by what the book says. But yeah, it is 60 to 70 or greater. The runoff from the study, so the runoff dye from the study shows a shadowy bulge that's seen in the thoracic artery. So the physician needs to evaluate the shadowy bulge. How is he going to do that? How are you going to look at it? You have to have an angiogram. So same thing. They go in with a cardiac cath, and the angiogram, they're going to let dye out contrast. That's right, contrast. And they're going to do x-rays to watch where the dye goes. So can she have this immediately after this cardiac cath? Why not? Yeah, they have to flush the dye. So if she goes in right now and has it done, you're just going to see one blob of dye. So you need to allow time for them to separate and allow time for the dye to leave the patient's circulation. So the patient needs to be given IV fluids and oral fluids to really push through. They usually wait 24 to 48 hours before doing the next one or repeating any type of contrast study. Okay, so hers is done 72 hours, and it shows a small 2 millimeter thoracic aortic aneurysm. So how can aneurysms be treated? Hers is small, so what do they do for small ones? Small ones you can do watch and wait, right? Yes, watch and wait and monitor. You're going to repeat the imaging study every 6 months to track any changes. What are some medications that will help this? What's happening when there's an aneurysm? What's happening to the wall of the aorta? Yeah, antihypertensives, right? So you want to get the blood pressure down so you can stop that pressure and the turbulence against that thinning side of the aorta. Um, you also want to avoid any type of stress. You need to keep any type of stress away from the weakening of the wall of the blood vessel. So to keep the blood pressure down. These enlarged aneurysms, they can be done. It's an open chest procedure. They have a Gore-Tex style graft tubing placed in the weakened area of the artery. So hers is small enough to watch because it's 2 millimeters. And I believe your book says it's anything less than 6 millimeters is watch and wait. So what are your nursing interventions? You got to prepare the family and client or patient for surgery. And how are you going to do that? You have to do your pre-op care. You have to know about your chronic health problems. Does the patient have hypertension, diabetes, any type of peripheral vascular disease? What do you need to know about the pulses in the lower extremity prior to surgery? So cardiac cath is going to go into your femoral artery, right? So prior to surgery, you need to be able to, yeah, what's their baseline? You need to be able to know what their characteristics of these lower extremities are so that you have something to compare it to after surgery. And prior to surgery, you do not want to be vigorously palpating the abdomen on this patient. You're going to monitor for any indications of dissection or rupture. You maintain the blood pressure at a low enough level to decrease the risk of rupture, but still you have to have it high enough to maintain perfusion. And then you have to promote these graft patency, not latency. I'll try to change that. And circulation post-op. So the general post-op care applies. You still have to maintain the blood pressure to facilitate the tissue perfusion. You're going to monitor for hemorrhage. And what are those signs of hemorrhage? Volemia, shock can be a sign of it. Low blood pressure, tachycardia, all those compensating signs. You can also have increased abdominal girth and back pain. The symptom of a graft occlusion. What is graft occlusion? The graft is blocked off. What are some symptoms of that? What would you be looking for? Think about it. Circulation's blocked off from that extremity, right? So you're going to be changes or decrease in the quality of the pulse. Yeah, pulses in the lower extremity. What about color, temperature, the coolness of the skin below the level of the graft? And any type of pain in the area. Hold on one second, I have to find my other ear thing. Okay, sorry about that. So you're gonna be looking for any type of pain in the area. Sometimes chest tubes have to be used because they have to deflate the area of the lung and they have to reinflate it. So you need to be making sure that they're functioning properly and draining properly. You're also going to be monitoring your urine output. And evaluating your BUN and your creatinine levels to assess for the renal function. And then home care teaching. So there's activity restrictions after they have any of these type of procedures done. No heavy lifting for 6 to 12 weeks. No activities that involve pushing, pulling, straining, any of those things that you know cause stress or any type of Valsalva mover. And obviously, because they've had surgery, they have to know the signs and symptoms of infection: redness, swelling, drainage, fever. Okay. Any questions about aneurysm? Y'all are thinking about HESI, aren't you? No, you don't need to know about Berry aneurysm. I know y'all are thinking about HESI. Okay, why don't y'all take a minute to use the bathroom? Take like 10 minutes, and I'll get the PD congenital heart defect PowerPoint up. Aneurysm can be on HESI, yeah. Okay, so 12:10, come back and we'll start this last part. I'll send you out a raising the bar for HESI. But remember, it's not all inclusive, but it's a good start. Okay, take a break. Okay, everybody back? So congenital heart defects, you have cyanotic and acyanotic. Acyanotic shunt from left to right, so the blood shunts from the left side to the right side. These are your ventricular septal defects, your PDAs, your patent ductus arteriosus, your atrial septal defects. These increase pulmonary blood flow. So these symptoms are the fatigue, murmur, the increased risk of carditis, and congestive heart failure, and they have a lot of growth restriction. You have coarcts that are obstructive pulmonary blood flow. They have the same classic symptoms as increased blood flow. And then you have cyanotic, which are your left to right shunts, and that's the TET, the targeted flow. It's mixed pulmonary blood flow. They do the TET, have TET spells, so they do the squatting to try to increase the pressure, basically do Valsalva maneuver by squatting. Okay, and then I'm going to show you this. We're going to go through each individual one. This is a VSD, so it's a ventricular septal defect. You can see the hole. Over ASD, it's the same as VSD, really. I just include them in the same because you on your boards or on HESI that say ASD, and I just don't want you to be freaked out by ASD saying you haven't studied it. So It's the same as ventricular, it's just the hole's in a different area. Okay, so ventricular septal defect, it's increased pulmonary blood flow, which I just told you. The hole is in between the ventricles. The oxygenated blood from the left ventricle is shunted and recirculated to the lungs. So it's the oxygenated blood from the left side is shunted and recirculated to the lungs. Now, these defects can close spontaneously if they're small. And large defects will cause, you'll have to have surgical closure. If they're not closed, failure. And these are all the things that I just said here. I just print them on there for you. I just wanted you to be able to look at the diagram while I was telling you. Then you have ASDs. The hole is in the atrial septum. This is also increased pulmonary blood flow. Hole between the atria. This oxygenated blood from the left atrium is shunted to the right atrium in the lungs. Most of these defects do not compromise the children seriously. They do need to be repaired. Surgical closure is recommended before school age. And that's because if it's not corrected, they'll end up compensating on their own, and it causes more problems in the long run. It puts them at risk for arrhythmias also and congestive heart failure. So ASD and VSD are both increased pulmonary blood flow. Then you have a PDA. In PDA, it's circled right there. It's that little bitty opening. It's used, the fetus needs it in utero. So it's used, it allows to skip the lungs during utero because the blood does not need to be oxygenated and the lungs are not oxygenating during utero. And then after birth, it closes so that the lungs can oxygenate the blood. So it changes the blood flow. This is also an increased pulmonary blood flow. It usually closes within 72 hours after birth. If it doesn't close on its own, or if it doesn't close, you have this oxygenated blood from the aorta returns to the pulmonary artery. This increased blood flow to the lungs causes pulmonary hypertension. If they're large enough, they can require surgical closure. If they're small, they can be treated with indomethacin or indocin. I typed it on the next page for you. And if you've ever had a NICU rotation or even a newborn rotation, you can often hear these murmurs before they close, especially in a new baby. And it sounds like a washing machine. And the wider it is open, the less noise that it makes, and sometimes you can't even hear them. And as they start to close is whenever the turbulence really happens, and you can really start hearing the blood whooshing around the flap as it's closing. And it'll cause this machine-type murmur. Then you have your coarc. So a coarc is an obstruction. So it's the obstruction of blood flow from the ventricles. It's in a narrowing that's in the aorta there. You can see it kind of goes in. The most common sites are the aortic valve and near the ductus arteriosus, which is by the PDA. You'll commonly find hypertension in the upper extremities or decreased or absent pulses in the lower extremities. You'll hear them say they want 4-point blood pressures on these patients. They want them on one on each arm and one on each leg. And you'll see often more than a 20-point difference in systolic pressure between the top and the bottom. So you'll have really high brachially, even radially. And then when you go and feel your pedal pulses or even your femoral pulses, there'll be a marked difference in the characteristics of the pulses. And these may require surgical correction. And it usually does require surgical correction. So the next one is tetralogy of Fallot. And This is decreased pulmonary blood flow. So it's a combination of 4 defects. So you have a VSD, you have an overriding aorta, you have pulmonary stenosis, and right ventricular hypertrophy. And you see the edge of the muscle there, how thick it is on this right side. The severity of this pulmonary stenosis really tells you, the severity of the pulmonary stenosis really tells you the degree of the right ventricular hypertrophy and the extent of the shunting that's going on in the heart. This one is tetralogy of Fallot. These patients will have what are called TET spells, usually in toddlers. They can maintain their own pressure pretty good whenever they're infants because their circulation is so small and so compact. But as they start getting a little bigger, the children, they'll start having these spells, and they'll naturally, instinctively squat or place in the knee to chest position. And this is so they can have increased pressure. They increase their pressure. Basically, Valsalva mover is what they do. It helps them get oxygenation. It helps their circulation and their perfusion. So don't be overwhelmed with the defects. Just know where the defect is at in each part of the heart. Okay, so ventricular septal defect, the VSD, is between the ventricles and the septum. ASD is between the atrium of the septum. A PDA is the patent ductus arteriosus, so it's the one that's going into the pulmonary artery that doesn't close. Your coarc is stenosis. In tetralogy of the 4 things we talked about, the overriding aorta, pulmonary stenosis, the VSD, and the right ventricular hypertrophy. Okay, so now we're going to talk about taking care of these kids. So your nursing assessment. They're going to have those clinical manifestations of congenital heart disease. What are some of those? Murmur, failure to thrive, yeah. They have growth restriction. They have cyanosis. So what would your assessment include with this patient? What are you going to listen for? Heart sounds, right? What about your pulse? About the difference in your pulses between the brachial and the femoral, right? You're going to want to look for quality and symmetrical. Your blood pressures, your oxygenation. They'll have oxygen saturations on these patients. So you can be giving them oxygen, and you can, on the left hand would be your pre-oxygen, and your right foot would be your post. It's called pre and post oxygenation. So you can see what the O2 sat is after it's supposedly gone through oxygenating side of the heart. And you can see that it's not, because you'll have a pre-sat of 89, and you'll have a post-sat of 70. So oxygenated blood is not getting all the way through. So some of your nursing interventions, basically caring for the child with this dysfunction, right? So you got to maintain hydration. These patients don't have adequate oxygenation, so their body starts telling them that they need more red blood cells and more hemoglobin, more hematocrit to get the blood around, or to get the oxygen around in their body, when that's not actually what the problem is. They're just not able to get enough oxygen because it's not going through, the blood's not going through the right chambers to be oxygenated. So the body starts becoming polycythemic, And when you do that, it increases the risk of thrombus formation. So you really have to make sure that you maintain their hydration to keep their blood, quote unquote, diluted out, less viscous. You got to maintain a neutral thermal environment. Any type of increase in temperature causes them to work harder. They need frequent rest periods. You got to organize activities to minimize the child's energy expenditure. And energy expenditure also goes with feeding. These children are growth restricted and they have poor feeding. Some of them can be failure to thrive. It's really hard when they're eating out of a bottle and they can't breathe or they can't get enough oxygen in. It causes them to be fussy and not want to eat, and that leads to the failure to thrive and the growth restrictions and them being below a certain percentile in weight. You want to be administering digoxin and diuretics. You got to get some of the fluid off of them to help with pulmonary circulation. When they have pulmonary hypertension, they have too much fluid in their lungs. Okay, and the digoxin. What's digoxin going to help? What's dig do? Contractility. That's right. Contractility, cardiac output. Okay, so it's going to help with that. And then you're monitoring your signs for deterioration of congestive heart failure, because you don't want them to go into congestive heart failure. And they're the same ones for adults. So what are some signs of congestive heart failure? It can be right or left sided. Shortness of breath, pulmonary edema, crackles, that's right. Vein extension. Yep. And edema in your extremities can also sometimes cause edema, and it can also cause ascites. So teaching the family about the use of prophylactic antibiotics before any dental or invasive procedures reduces the risk of endocarditis. They have to know about this. You can't have an infection in the heart on these patients. And then we talked about infants may require tube feeding to conserve energy with any of them. Diagnostic test. So what's your echocardiogram going to show? If you did an echocardiogram on a heart patient, what can it show you? Yeah, where the defect is. It can tell you if there's decreased pulmonary blood flow. It can tell you if there's anything going on with your right ventricle. Is it enlarged? It can tell you if there's a reduced size in the pulmonary artery. So you can basically look at the heart during an echo. It can tell you where the blood is being shunted to, because you know they can turn it to where you can see the oxygenated and unoxygenated blood, and you can see where the shunt's at. What about your electrocardiogram? What can it show you? It can show you dysrhythmias. It can also show you the size of your right ventricle. So if you have any right ventricular hypertrophy, then it'll show on your electrocardiogram, your EKG. And then your cardiac catheterization and your angiogram, they're done prior to surgery to show the extent of the structural defect. And so they can get a better picture. You can get a pretty good picture from an EKG and from an echo, but you really can't know the extent of it until you go in with cardiocath and angiogram, so that you can see everything before they actually go in and do the open heart surgery. So caring for these children, preparing the family and child for the catheterization, the risk factors of catheterization, you need to know these. That there's arrhythmias, they're at risk for bleeding, any type of perforation that goes on when you're in there. Anytime you have something that's a little bit small heart, think about the heart the size of a baby's hand, baby's fist, and you're going in with a catheter and rip anything in there. Phlebitis and any type of obstruction at the entry site. That'll be an arterial obstruction at the entry site. It can cause a clot that won't allow any blood to pass through, but you'll have that occlusion from below. So you'll have your distal peripheral pulses will be diminished, extremity will be cold, and just lack of perfusion. Okay. Obviously, you have to monitor vital signs, incision site, and cardiac rhythm. Arrhythmias going into the heart, you really irritate the heart with the catheter, and you can often have arrhythmias during that. You're going to be watching for bleeding and also infection afterwards. And appropriate teaching for age for the child. So showing them the ICU, explaining the chest tubes and lines, monitors, dressings, ventilators, different procedures that are going on. They'll see so many different things when they go in there. And if it's appropriate for age, and sometimes it's not even age, sometimes it's the child's comfort level also. I mean, I have a 13-year-old daughter. If I took her into a cardiac ICU and showed her a chest tube, she'd pass out, she'd be laying on the floor. So you also have to take the child in consideration. You don't want to force any of it on them, but you want to do what they're comfortable with. Using a doll, if y'all have done your Scottish Rite rotation, using a doll or using any type of techniques where you allow them to listen to your heart with a stethoscope or listen to the heart of a teddy bear with a stethoscope, it helps them think of it as non-threatening. And then emotional support, as always, to the family. Your surgical procedures, I put this on here more for you to know what you're monitoring for after. I do want you to know what the names of them are, but you do not have to know exactly the whole procedure itself. You're not going into cardiac surgeons. You just need to know how to care for them after and what to monitor for. So if a VSD requires surgical closure, some of them will be what you call a muscular VSD or ASD, and it will close on its own. But the ones that don't close on their own, they do have to have surgical closure. And it has to be done, I talked about this earlier, before any vascular changes or permanent vascular changes develop, before the body starts compensating to try to make everything okay, basically. So the pulmonary vascular system will change to accommodate the increased blood flow or the increased flow to the pulmonary side of the lungs. And once those changes start to develop, if you correct that VSD, critical time after that where the body's trying to compensate back to normal. And those kids come out really, really sick. So surgical closure can be used with a suture. It can be a device that's placed in the hole, or it can be a patch, a Dextron patch, which is just a closure patch. Obviously with those, you're also going to look for any type of rejection. And then you're monitoring for dysrhythmias, ventricular dysrhythmias after you close up this VSD, because you've irritated the ventricular of the heart by surgery on there. So you're watching for those ventricular dysrhythmias after. You're watching for any type of rejection, bleeding, any type of change in cardiac output, any type of decompensation that would be going on. Same thing for ASDs. If it's small, it can close on its own. Some of the small ones have to be closed with just a suture. Some of them require a patch or a synthetic material. They can have arrhythmias lifelong after the surgery closure because of the closeness to the SA node. Same thing after surgery with them. You're watching for all the cardiac output and any type of decompensation cardiac-wise. PDA. Coiled embolization, I don't really need you to know that. I've seen some of the ways that it's done. They're usually done by a staple now. They do them through cardiac catheterization. They deflate the right lung during their procedure so they can get to the heart, and it's called ligated. So they'll put a staple basically around that band and close it off. And you can see it on an x-ray, and it looks just like a staple on an x-ray after a kid that's had one. And it closes it off, and it does what the body should have done naturally and corrects the blood flow in the heart. It can also be done by indomethacin, which we talked about a little earlier. That's the medication that will allow or help close the PDA. It does have some complications with indomethacin. The shunning of blood, which takes the blood and the perfusion away from the gut and the intestines. These patients really have to be monitored for any type of GI intolerance, which could be residuals on their feedings, any green gastric fluids. They can perf because of this. And they can also have necrotizing enterocolitis, which is necrotizing is death, right? Death of the intestines in certain areas, which can become septic. So the patient has to be a good fit for indomethacin. It's done in stages. It's done at one dose, and you get 3 doses at that level. And then they'll do an echo to see if it's made any changes. And if it hasn't, they increase the dose, and you at that, and they'll do a repeat echo. Do give 3 doses for it, or three sessions for it, but very go ahead and go do the 3 sessions, because usually it will close definitely by the 2nd dose, but usually by the 1st dose you can see it start making some movement and closing. And remember, on PDA, you may not hear it because it's wide open, but you'd be on an echo, you'd be able to watch and follow the blood flow in the echo. And as it gets closer to closing, the louder and the more just turmoil around the actual closing of it causes the louder sound for the murmur. So the louder the murmur, the closer it really is to closing, which seems kind of opposite what you would think. The more open it is, there's no turbulence or disturbance in it, so it's not making any sound. After they're surgically ligated or closed with the staple, you do have to monitor them for bleeding and any laryngeal nerve damage, because you're so close right there to the nerve whenever you go in. They'll also have chest tubes when they come out. You have to make sure the chest tubes are functioning properly. In COARC, the most common surgical repair on this is resection of the narrow parts of the aorta, and that's followed by a reanastomosis. So they basically just take that skinny section out and just put the big sections back together. So prostaglandins are given after this, and they relax the heart tissue, the ductal tissue here, and just help it to heal and to not be under any type of stress. It's almost like kind of a muscle relaxer for the heart. You're going to be measuring their 4-point extremities blood pressure, which we talked about. This is the one that'll have, you need 4-point blood pressures. You can kind of diagnose it by that also. And you're going to be following their quality of their upper and their lower pulses. You're also going to watch for any type of bleed or risk for perforation, because you've taken it completely apart and putting it completely back together. It is sutured around. So to make sure that the sutures are holding and there's not high pressure to want to blow those sutures out. And then tetralogy of Fallot. Like I said, I don't want you to go crazy about the actual procedures here, because they're quite in depth, and you're not going to be a cardiac surgeon at the moment. But after they do the reanastomosis for the pulmonary side, for tetralogy of Fallot, Blaylock, Watterson shunt, you're going to avoid the blood pressure and venipuncture in the affected arm, because what they do is they take the subclavian artery and use it for the shunt. Okay, so you won't do any type of blood pressures, venipuncture. Same thing as a person that's had breast cancer, how you don't mess with that side of their arm as far as for their lymph system. It's kind of the same thing here, except for they don't have that subclavian artery. So you're monitoring for ventricular arrhythmias, because remember there's a VSD and that it's got to be repaired. You're monitoring for the pulmonary pressures in the side of their heart. You're monitoring for any bleeding, any changes in cardiac output, any signs of heart failure. Okay, and now I have just some questions for you for the rest of the slides. We're just going to kind of talk through some things. And I think it'll help you, because the heart can be overwhelming at times, especially when it seems like it's so much and so much is new. So we talked about cyanotic and acyanotic defects. So what are the basic differences between this? Yeah, one impairs oxygen delivery. Which one? Okay, so cyanotic has abnormal circulation with unoxygenated blood entering the systemic circulation. And acyanotic has abnormal circulation, but the blood entering the systemic circulation is oxygenated. Does that make sense? So one of them has impaired circulation, but the blood's not oxygenated. And the other one has impaired circulation, but the blood's oxygenated. Which one? Which one has oxygenated blood? Acyanotic, that's right. And cyanotic has unoxygenated blood. Good. So your VSDs, your ASDs, your PDAs are your left to right shunts. Yes.
Sorry, Ms. Maljack, I'm not going to sit here and lie to you.
It's okay.
Oxygenated is acyanotic? No, yeah,
Oxygenated is acyanotic. So yeah, so not cyanotic. Think about it that way. Acyanotic is not cyanotic.
Okay, and you said that it's oxygenated, but there's a problem with blood flow? I didn't catch that last part.
Yes. So they both have abnormal circulation.
Okay.
But acyanotic has oxygenated blood, and cyanotic has unoxygenated blood.
Okay.
So the acyanotic has abnormal circulation, so it does have oxygenated blood, but the blood's not going where it needs to go.
Okay.
Even though it's oxygenated.
Okay, thank you.
Does that make sense to everybody? You're welcome. So both of them are disturbances in circulation. They have abnormal circulation. Cyanotic is not oxygenated. Acyanotic is oxygenated. The blood just can't get there. Okay? So which shunts do the cyanotic defects have? I put the answers on here so y'all have them when y'all studying. What shunts do cyanotic defects have? They go left to right or right to left? That's right, right to left. They bypass the lungs. So cyanotic, think about this, cyanotic, no oxygen, right? They bypass the lungs. Makes sense, right? It's got to go through the lungs to get oxygenated. List the 4 defects that are associated with tetralogy of Fallot, or TET. Pulmonary stenosis. Okay, we got 1. VSD, there's 2. Right ventricular hypertrophy, yep. What's one more? Overriding aorta. Very good. Yes, Jessica.
Sorry, my waffle was in the way.
That's okay. Do you have a question?
No, sorry, I was eating breakfast and I sorry.
All right, enjoy breakfast. Okay, so it's the VSD. It's the VSD, it's the overriding aorta, pulmonary stenosis, and right ventricular hypertrophy. Okay. What are some common signs and symptoms of cardiac problems in an infant? Poor feeding. If they're poor feeding, what do they have? Poor weight gain, failure to thrive. What else? Respiratory distress also. Cyanosis. And edema. Okay. So we have poor feeding, poor weight gain, respiratory distress and infections, edema, and cyanosis. Infection in the lungs, yes. Also any, but yeah, in the lungs. So what are the 2 objectives of treating congested heart failure? And I'm not just talking about a child, I'm talking about anything. What are your 2 objectives? What are you trying to do to help that heart out? You want to increase cardiac output, and you want to decrease the workload. Yep. Okay, same thing for the little people too. So what nursing interventions reduce the workload of the heart for these patients? Cluster care, rest periods, morphine if you're going to drug them. So you want to give those small frequent feedings, or even gavage or NG feed the infants. It takes a lot of calories and a lot of work for them to eat. You want to plan frequent rest periods, maintain that neutral thermal environment. And then you want to organize your activities. So basically cluster care, if they can handle it. Some of them can't handle cluster care, but if they can handle cluster care. What position would best relieve the child experiencing a TET spill? What position did I tell you they like to go into? Yeah, knees to chest or squatting. What are the 5 risk of, or at least of cardiac catheterization? Y'all know this. Okay, arrhythmias, bleeding, perforation, phlebitis, and obstruction of the arterial entry site. How do beta blockers help these patients? Slows the heart rate and improves contractility. And improving contractility does decrease the workload of the heart because it's more efficient. Here's y'all's favorite ones. Which nursing intervention is most appropriate when caring for an infant with heart failure? Good. Yeah, cluster care. Which treatment plan is recommended for an infant with heart failure? Yep. You want to use formulas with increased caloric content. Remember I told you they use a lot of calories trying to eat. They also use a lot of calories with their heart defect and trying to compensate all the time. So these patients, it's twofold of why they're growth restricted and low weight for their age. Okay, so as many calories you put into them. You would never restrict their fluids. Weighing them once a week is not going to tell you anything, and low sodium is not going to do anything for them. And you don't want to do that. What happens if you get low sodium in an infant? Think about giving a baby water. What happens? You dilute their sodium out, right? What happens? Seizure. That's right. See, y'all do learn something from me. Okay. Mother is holding her son born with a PDA 6 hours ago. She states, doctor says that the baby has a heart murmur. Does it mean he has a bad heart? What's your most appropriate response? Good. Yep, it can take a day or two to close. It's part of the normal transition. Yes, Jessica.
I am so sorry to backtrack, but whenever you said the risk for catheterizations and you put perforation of the fixing or perforation of the heart, or
The heart, anything along the way, honestly. I mean, if they go in through the femoral artery, they can perforate the artery any way up, but any part of the heart also.
Okay. Okay.
They can perforate the septum. I mean, they can perforate the wall. They can perforate any of it. Okay, so which assessment finding would the nurse suspect with a child who has a digoxin level greater than 2 micrograms per milliliter? Are y'all cheating? Are you looking at the next slide? Yes, it's right. No, I sent them out to you. But I know you're looking at the next slide. No, you are smart. Okay, which intervention is recommended initially for preterm neonates to close the PDA? That's right, indomethacin. And we talked about prostaglandin. What did I tell you prostaglandin did? It relaxes, right? So there are some defects. We're not talking about them right now, but I just want you to know some of the defects. You need the PDA to stay open so you have circulation in the heart, and you would give prostaglandins then. So prostaglandins basically relax the heart. They keep those ducts, the PDA open. Okay, so it, prostaglandin keeps it open. You want indomethacin. Okay. What would make you suspect the VSD in this patient? It's a 4-month-old, 10 percentile weight, 95 percentile height, frequent bradycardia, tachypnea, breastfeeding every 4 hours for 30 minutes on each side. Oh, it's a select all that apply. Sorry about that. Okay, so tachypnea, the baby plots 10% in weight and increased length of time to finish breastfeeding. 30 minutes each side every 4 hours. That's an hour of feeding every 4 hours. It's usually 30 minutes total, like 15 minutes on each side. Okay, so that just shows the baby's having a difficult time breastfeeding or eating. So infant returns to the room, cardiac catheterization. What priority information should the nurse teach the patient or the parents about mobility? Select all that apply. Can y'all hear my dog? He's so embarrassing. I'm so sorry. Okay, so let's go at them one at a time. So you wouldn't want the infant to sit in a swing. He's not singing, he's snoring, he's painful. Okay, so you wouldn't want the infant to sit in a swing, right? Sitting up, if he's had a cardiac catheterization and you've gone in the femoral artery, you sit up, you put pressure on that artery, right? So you need to be able to stop the bleeding and make sure that it clots off well. So no sitting up in the swing. So the infant, because it is an infant, it can be held as long as the extremity is immobilized. May maintain bed rest with the affected extremity immobilized. You would not want to hold the infant upright in your arms in order to eat at that time. Okay. So a nurse is assessing the child 1 hour after cardiac cath. Yeah, it's because of pressure, just hemorrhage, risk of hemorrhage. Okay, so the nurse is assessing a child 1 hour after cardiac. For which finding would the nurse immediately alert the provider? Good. Yep. Weak, thready, unequal dorsal pedal pulses. It shows an obstruction and definitely a change from pre-op pulses. The nurse is preparing to assess a child with possible cardiac anomaly. What is the priority assessment for the nurse? Which one of our defects would 4-point extremity blood pressure? Which one would alert you? If you had a patient and you did COARC, COARC is the one where your pulses, your upper extremity pulses and your lower extremity pulses. Upper extremity pulses are going to be normal, if not bounding, and your lower extremity pulses are going to be extremely thready and definitely weaker. Okay, so it's a COARC. But yes, blood pressure in all 4 extremities. Okay, which change would the nurse anticipate after administering oxygen to a cyanotic infant with an uncorrected tetralogy of flow? Yes, less agitation. That's right. The infant will be less agitated. It's part of that air hunger. Good job. That's all on pediatric perfusion. What questions do you have for me? What is overriding aorta? It is an aorta that's placed above, over or above a VSD. If you go back to, let me show you on the TET slide. I'm gonna go all the way back. Good, very a lot of slides. You see where the VSD is at in this picture, and you see where the overriding aorta, it comes down right where the VSD is at. Yes, I can send out the recording from last week's lecture. I will send out the Raising the Bar for HESI. And like I said, it's not all inclusive, but it gives you, it kind of gives you a starting point, especially hit some of the stuff that y'all may have learned in another semester. I have a lot of extra things for perfusion, like question. I think I told you this last week. Questions, discussion questions, fill in the blanks, multiple choice. You don't have to do them. You can do them. If you send them to me, I'll give you the answers, but it's not, it's not required. Yes, Jessica.
I hate to be a noob and ask you, but it's a stupid question, but as I already said, there's no stupid questions in life. So I wanted to ask you if, oh God, this is so stupid. If on HESI, if we're going to be tested on things that we haven't learned, because this is so stupid, I swear. I'm going to be using the Red HESI book. I'm sure everyone probably will be too, but I'm just confused because I'm like, the Red HESI book is like the ocean and we've only learned like a pond. So I'm not sure like if I should prepare for the worst and like, kind of learn everything or if I should just kind of review what we've already learned in past semesters. I'm assuming that they're not going to teach, they're not going to test us on like freaking, a chemotherapy or something because we didn't really learn that much in depth other than like the basic meds. So, or like dialysis.
It does focus on what you've learned or what could be covered in fourth semester. But I'll tell you this, if you get to stuff that you just absolutely don't know when you're studying, don't try to learn it right now. Learn the stuff you know. Like learn the stuff you've already done. Don't try to, really focus on the stuff that you don't know. I know that kind of sounds stupid, but you're not going to learn it before HESI.
No,
but you can really definitely get the stuff you know right.
To be honest, Ms. Raljak, I don't really know that I can learn anything else at this point. I think I have increased ICP. I don't know really what else to learn. So I'm just going to stick with what we've been taught and just kind of go with it.
It's definitely, it should be just more of a review, honestly. Just freshen up on things that you haven't seen in a while. Headset, I don't know. I've got to ask that. Oh, it was on email. Okay, never mind then. It was on email. Just like headphones, right? Isn't that what you're talking about? Like plug-in headphones? Sometimes those questions have sound, right? Yeah. And test review, unless y'all just want to do it this week, I don't really want to do it this week. I want you to focus on HESI. So we can do it after HESI. I can put out a sign up Genius for that week, like right after HESI, starting on Monday evening or Tuesday morning. Does that work? Exam 3 is just perfusion. Last week and this week classes. Jessica.
Sorry, Ms. Raljak. I have anxiety. Is it 125 or 165 on exam on the HESI? I think it was 125, or maybe it's just 75. I don't know.
I think it's either 160 or 165. It's definitely 160 something.
Okay. And then I think it's 5 hours. I think is what I read. I don't know.
I believe that's correct.
Okay. All right. Thanks.
Yes, there's an exam 4. What else?
What are we supposed to do with our receipt from HESI?
Is there a place in Blackboard to upload it?
Not that I've seen, but that doesn't make it so.
Just email it to me. I know that doesn't make it right. Just email it to me.
Okay. All right. Thank you.
Uh-huh. I can confirm that. I'm not there when y'all test. Okay. It's your ticket in, but email it to me also. I have to have it down somewhere, and most of y'all have emailed it. Yes, I will send a perfusion raising the bar. You can email it to me. I'll put my email down here. Anything else? I'll try to send everything out for perfusion. I would say tonight, but definitely by the morning. I'll go ahead and send all the questions. I'll send the raising the bar. I'll send the recording from last week. Is that all? Oh, you prep, yeah. I mean, prep you, yeah, prep you. Yes, I'll get prep you done. And the HESI raising the bar. Y'all are welcome. Okay, if y'all don't have any other questions, y'all are free. You got 30 minutes extra HESI studying time. If you have questions, you can stay on and ask me. If not, all are good.